We're excited to be here to talk about pulmonary hypertension at a Pulmonary Fibrosis Awareness Day. So pulmonary hypertension, quite simply, is the situation of having high pressures in the lungs. The pulmonary blood vessels, the pulmonary arteries, are normally a very cool customer. The pressures are low, and the pulmonary arteries have this amazing ability to adapt or to increase their capacitance under circumstances of stress, assuming that the organism is healthy. Under conditions of stress, the pulmonary artery can increase its capacitance by a degree higher than we can mount a cardiac output increase. And so under conditions of normal physiology, not only does the pressure in our lungs not rise under periods of physical stress or increased cardiac output, it actually decreases. Various disease states can cause that pressure to be elevated above where it's supposed to be. And we define pulmonary hypertension, or an abnormally high pressure, as a pressure equal to or greater than 25 millimeters of mercury. Pulmonary arterial hypertension, or what I commonly refer to as a disease of pulmonary blood vessels, also assumes that there's not another secondary cause for that elevation in pulmonary pressure. A lot of emphasis put on what is the wedge pressure, or a surrogate marker for the left atrial pressure. And in order to have pulmonary arterial hypertension, not only does the pulmonary artery pressure need to be greater than 25, but the wedge pressure needs to be less than or equal to 15. As the pressures rise in a state of illness, the elevated pressures and the increased resistance to flow coming out of the right ventricle and through the pulmonary arteries puts an increased strain on the right ventricle, and this is what causes, in a sense, the symptoms that people with pulmonary hypertension develop. The right ventricle, over time, cannot do the work necessary to adequately circulate oxygen-rich blood flow through our bodies. There were many different causes of pulmonary hypertension. Category 1 is, as I referenced, a disease of pulmonary blood vessels. This is a disease wherein those normally very pliable, very accommodating, very flexible pulmonary arteries become stiff and rigid, potentially in association with other systemic diseases, connective tissue diseases, sometimes medications, and sometimes other diseases. Group 1, pulmonary arterial hypertension, is a disease here at the pulmonary arteries. Group 3 pulmonary hypertension, which is pulmonary hypertension that arises in patients with chronic respiratory disease. It's really complicated. Typically speaking, the changes that lead to pulmonary hypertension in association with chronic respiratory disease are here at the alveolar capillary membrane. If the initial insult is interstitial lung disease of any different etiology, some of the changes that we start to see occur include obliteration of blood vessels. All those tiny branches of the pulmonary artery are running out through the spongy lung tissue, which is no longer spongy. And where there's destruction of spongy lung tissue, the tiny blood vessels that run through that lung tissue are also destroyed. With vascular obliteration comes changes in pulmonary blood flow. The body starts elegantly matching blood flow to airflow to maintain this fine balance to make sure that we get enough oxygen in and enough carbon dioxide out. But these changes potentially can go awry. Things can go so far off the rails that they lead us to new problems that we didn't have before we had the interstitial lung disease.
The prevalence of pulmonary hypertension and interstitial lung disease is actually, we don't know. It affects a vast number. This is something for patients who have pulmonary fibrosis. This is a big deal. Echocardiogram, which is often a way that we screen for pulmonary hypertension. This is right heart cath, so this is the gold standard. Certainly right heart cath picks up more pulmonary hypertension in these patients as opposed to a screening echocardiogram. Why do we care? I mean, so what? Pulmonary fibrosis sucks enough. We don't need another problem, right? Well, unfortunately, what we see in pulmonary fibrosis and PH is worse outcome. Most patients with pulmonary fibrosis without pulmonary hypertension, their 3-year survival is not so bad. Well, as the PA pressure goes up, as noted by these checked hash lines, the higher the PA pressure, the worse your outcome. So the association of the two is a very bad sign.
It's pretty clear that we need to do something about that.
Well, I don't know. You've got a good point. In the world of pulmonary arterial hypertension, we have had a golden era starting back in 1995. We had our first drug available for pulmonary arterial hypertension. Of all these other drugs and drug classes that became available to us to treat pulmonary arterial hypertension, being defined as high pulmonary artery pressure and no lung disease. Pulmonary arterial hypertension, not pulmonary hypertension associated with pulmonary fibrosis. So even though we have lots of hammers and have lots of tools, maybe, as my wife likes to tell me, I shouldn't be doing that. And I want to give you some data as to why this is actually true. Here's a study looking at use of sildenafil in advanced pulmonary fibrosis. These are fairly sick IPF patients with diffusion capacities less than 30%. Diffusion capacity is kind of a marker of how much lung disease you have. It was a double-blinded randomized controlled trial, so 12 weeks long, 89 in the treatment group, 90 or so in the placebo. The primary outcome was, can you walk farther? Can you walk farther at 12 weeks after taking Viagra? And the answer is no. Any of the secondary outcomes didn't really meet statistical significance. Here's clearly a trial that had no benefit. So BUILD 3 is another trial that randomized and controlled trial patients of idiopathic pulmonary fibrosis, the use of bosentan. That's basically, it showed no difference in all-cause mortality. It showed no difference in time to clinical worsening.
Come on, man. You're missing the most important 3 words on that slide. No reported pH. I'm not talking about using bosentan or medicines like that to treat pulmonary fibrosis. We're talking about pulmonary fibrosis-associated pulmonary hypertension. They didn't even report.
Associated blah, 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 blah. Let's look at another study, Artemis IPF. Artemis IPF was looking at ambrisentan and IPF, and it was stopped early due to lack of efficacy. Ambrisentan is much like bosentan. It's an ERA that we use for pulmonary arterial hypertension. It didn't work, but he did make a good point on the last study. He said, well, that BUILD study, that's crap.
At least they tried.
You didn't include pulmonary hypertension. Well, Artemis PH was geared towards patients with IPF with right heart cath diagnosed pulmonary hypertension. And in fact, it was also stopped early. Why? Because it didn't work. Another study keeps getting better. The study called RISE-IP. This was the use of Resealguat in patients with pulmonary hypertension associated with idiopathic interstitial pneumonias, some of whom had straight idiopathic pulmonary fibrosis. And the primary endpoint was, could you walk farther at 26 weeks? In this study, they also killed early. Why? Because people were dying. The data would suggest to us that our toolbox for pulmonary arterial hypertension is overflowing. Unfortunately, our toolbox for pulmonary hypertension associated with pulmonary fibrosis, maybe these aren't tools. It might worsen our patients or certainly even hasten their death. You can see all this architectural lung disease. These blood vessels are toast. They are gone. And so these medicines that work on those blood vessels, well, they work on those blood vessels if those blood vessels are there. The body moves blood away from those areas by vasoconstriction. But if we give these medicines that systemically vasodilate our blood vessels in our lungs, that upsets that process. And we're starting to shove blood back to these areas of lung, which then make oxygenation worse. And in some cases, as the study shows, maybe makes you die. I would say maybe that toolbox needs to be left on the shelf.
All right. So maybe I got a little overexcited about STEP IPF and BUILD 3, but you know as well as I do, they didn't ask the right question. What is this pulmonary hypertension? Well, we already saw from the World Health Organization that we've got 5 different categories of problems that can cause pulmonary hypertension. That tells you that pulmonary hypertension in general is a heterogeneous entity. It's not the same in everybody. And I would dare say that pulmonary arterial hypertension is also heterogeneous, even though we're talking about one of 5 different groups of pulmonary hypertensive disease. Because, okay, I got you. This is a disease of the pulmonary parenchyma. This isn't primarily a disease of the pulmonary vasculature. Are you telling me that if flooding affects an electrical grid that causes a huge fire that threatens to take out a couple of city blocks, that we shouldn't call in the firefighters to fight the fire because a hurricane is a problem with flooding? Not so fast, my friend. What do you do? What do you do?
Okay, Siskel weatherman.
Hang on. What do you do when your patient with pulmonary fibrosis has this echo? This is no longer a problem with scarring of the pulmonary parenchyma. Look at this right ventricle. And this is somebody that I'm telling you has pulmonary fibrosis. But not every patient with pulmonary fibrosis has this. Those other folks that you referenced didn't ask the right question. And I'll grant you that treating pulmonary hypertension in every patient with pulmonary fibrosis associated pulmonary hypertension is probably not a good idea. But because I believe, and I think the data is starting to suggest, that pulmonary hypertension is very heterogeneous in this group, I think we've got to ask, are there subgroups of people who have pulmonary hypertension with pulmonary fibrosis who have gone off the rails and have echoes that look like that maybe we should be doing something about? And it turns out that there's some awfully bright people out there who have asked that very question. So I present for your consideration a trial, a prospective trial, and they tried to identify people with pulmonary fibrosis referred for lung transplant who had the most severe forms or manifestations of pulmonary hypertension. Of the 15 patients that they enrolled, they decided, hey, if we're going to do this, we're going to say that these are some of the most ill patients with pulmonary fibrosis and associated pulmonary hypertension. We're going to use our #1 hammer. We're going to use treprostinil, one of the gold standard medications for the treatment of pulmonary vascular disease that may help rescue the right ventricle. These people were profoundly sick. What they did is they took baseline measurements of pulmonary function, both by spirometry, lung volumes, and DLCO, and by 6-minute walk test. They also did a baseline assessment of their dyspnea index, or their quality of life, or their symptom scores. Treated these patients for 12 weeks with predominantly subcutaneous treprostinil, and you'll notice that the lung function variables really didn't change. These patients did not get any worse from an hypoxemia standpoint, and yet baseline right atrial pressures, again a marker of that the right ventricle and right atrium are struggling, were close to 10. After 12 weeks of therapy, it fell to 6. That was statistically significant. And so along those lines, I think that we have the sense that pulmonary hypertension and pulmonary fibrosis is not pulmonary hypertension, and there's a tangible number of people out there that we could potentially make a difference for. But consider the group of people who have a truly advanced form of pulmonary hypertension. Consider sending those patients for referral to an expert pulmonary hypertension center, because that's not the same group of people as people who don't have those high-risk features.